Hi, I'm Dr. Matt Lewis, and I'm excited today to present to you on behalf of AAPTE, talking about irritable bowel syndrome and a functional medicine or holistic approach to irritable bowel, excuse me. And that includes Crohn's and colitis. So I've been practicing functional medicine for 20 years. I'm a diplomate of the American Board of Clinical Nutrition and a certified functional medicine provider. And I've been practicing, with patients with respect to digestive problems for quite a while, and have had a good deal of experience with Crohn's and colitis. I'm going to share with you today an example, a patient example. I'm going to go through with you what Crohn's is, colitis, and so you'll have a better understanding and how you can help yourself or someone that you may know who might be experiencing problems due to Crohn. So I'm showing you this because it's kind of intuitive, but it's often forgotten in the conventional medical model. But food plays a huge role in all chronic conditions, whether we're talking about diabetes, heart disease, digestive problems. And so, I just like to use the analogy when you think about the types of foods that you eat. Let's think about foods that are going to be, whole foods, fruits, vegetables, fish. But we have to work on foods that are easier to digest, especially if we have a chronic condition. Because in any chronic condition, particularly Crohn's, colitis, if we're talking about chronic conditions of the GI system, we'll have a certain amount of digestive involvement, even if it's not a digestive problem. People with heart disease, diabetes, often have digestive problems as well. What's easier to digest, like a cheeseburger or an apple? Clearly, the answer is apple. So I'm going to go through some of the research here and just to teach you a little bit about Crohn's disease. So Crohn's disease and ulcerative colitis are commonly referred to as inflammatory bowel disease, which is different than IBS, which is irritable bowel syndrome. When you have inflammatory bowel disease, that's a chronic condition. It's autoimmune. So they're immunologically mediated inflammatory diseases of the GI tract. In Crohn's disease, the difference is the inflammation can extend the entire length of the bowel, from the bowel wall all the way through the mucosa, and it's going back and forth. People who have Crohn's or colitis, they'll relapse often. So they might get into a situation where they get on pharmaceutical medications, where they're taking immune suppressant drugs to calm the immune response. But even with that, they may have relapses. In Crohn's disease, you can get what are called fistulas or stricturing or scarring in the intestines. And for Crohn's, it's going to affect both the small intestine and the large intestine. Different than ulcerative colitis, where we see it's mostly, you're going to see, as the term suggests, colitis in the colon only. Crohn's a little bit more widespread in the gastrointestinal tract, whereas colitis is going to be usually in the colon. It can affect any part. Crohn's disease can affect any part of the GI tract. About 1/3 of patients will have small bowel involvement, so also in the small intestine, like I just said, especially the last part of it, or what's termed the ileum. And another 20% only have colon involvement, so you have colon involvement. And 50% of the people have both colon and small intestinal or small bowel involvement. This is important. This is coming from the National Library of Medicine. There is no cure. And like I said, most patients will experience bouts of remission and relapse at unpredictable times. This leads to very poor quality of life. And so the approach that we're going to talk about today, this holistic approach, is looking at how do we improve quality of life. And I want you to also understand that in recent years, there have been a number of developing countries that have witnessed a slow increase in the incidence of irritable bowel disease, which seems to have occurred as these countries have started to westernize. Back to the apple, right? As we westernize, what do? We eat more processed, refined foods, more sugar, more fat, less fruits and vegetables. And so what we're going to see is that Crohn's disease, irritable bowel disease, these are genetic with respect to the fact that you have a greater likelihood, the risk is really strong if there's a family predisposition, so mom or your dad or your cousin or your aunt or somebody in your family, a grandparent, had Crohn's or colitis, then there's more likelihood that you have that genetic material and you will be more likely to have Crohn's. However, you're going to see that is not just having the genetics alone will not cause the problem. So there's more to the story, right? And I think this points that out fairly well, because when you change diet, you see increase in places where you really didn't have as much of these problems. So just to share with you again, Crohn's disease here, just to give you a visual, it could have inflammation. So that's what we're looking at, inflammation. That's immune response. Your immune system, for a variety of reasons, is becoming inflamed in the GI tract, and we'll go through some of those things later. And then in Crohn's disease, you see it in the large intestine, but also in the small intestine. And then you see here in ulcerative colitis, it's basically in the large intestine. You don't see anything going on in the small intestine. Now, you go to a doctor and they do a scan or a colonoscopy, make the diagnosis of some of these findings. And you can see here in Crohn's disease, we have what's called a cobblestone appearance on the surface. It gets kind of patchy, thickening of the colon wall. So you see this colon wall gets thick. So here, this is a normal colon. And it's very important that the colon is nice and smooth and flat. You do have these little indentations here, but that's normal. And what's going on here is you have what are called villi, and that's where you have your surface area. So the wider the colon, right, you have more surface area, you're going to absorb more nutrients. This is really important. And then as we get into Crohn's disease, you can see the wall of the colon, that's this part here, right in here, is getting thicker. So you're losing surface area. So you're going to have malabsorption. You're going to find vitamin deficiencies, mineral deficiencies, poor absorption of proteins, fats, and that would be occurring in the small intestine. Obviously, as you have inflammation in there, that's where most of the absorption is taking, most of the digestion and absorption is taking place. When you get into the large intestine, again, you want all of this to work real well, but we can see you can get what's called a fistula. And a fistula, what happens is this, you're actually developing like a hole that's going from the surface of the inside of the colon and moving its way outside. Now, the problem is in here, this is coming because you're recruiting immune cells, you're building inflammation, you can get pus formations in there, you can get infection, and as it starts to come out, it could break the colon wall. Even if it stays in here, you start to get infections in here, and it's very uncomfortable for people. So again, from the National Library of Medicine, although the exact etiology or cause of inflammatory bowel disease is not known, there is substantial evidence to suggest that the disease is resulting from an inappropriate immune response in the bowel to situations from environmental factors such as drugs, toxins, infections, intestinal microbes in a genetically susceptible host. I want to break this down a little bit here because it almost doesn't make sense what they're saying. It says, although the exact cause of inflammatory bowel disease is not known, there is evidence to suggest X, Y, and Z, which is that drugs, toxins, infections, and dysbiosis or poor bacterial counts in the digestive tract will actually bring on disease. So if you just have the genetics and you're not influenced by drugs, toxins, and infections, there's a lot less likelihood of you developing. So we, in fact, do know in large part what causes these problems. What they're saying is we don't really focus on that part of treatment, number one, in the conventional sense. What we look at is we say, hey, this person's having a too robust of an immune response. Their immune system's overacting. Well, maybe it's because of the foods that you're eating or that someone's eating that the foods have preservatives and chemicals and environmental toxins that could be coming from a multitude of places, obviously. Medications that people take, like later in my presentation, that people who use non-steroidal anti-inflammatory medications like Advil, Tylenol, that could bring on a case of Crohn's or colitis. So there's a lot of causes of antibiotics use. Okay, that's a drug that can bring on Crohn's and colitis. So to say we don't know is really not accurate. And I know a lot of patients that I see are frustrated because they've been to a provider, multiple providers before they got to me. They've been diagnosed with, Crohn's or irritable bowel disease. And the doctor says, yeah, nutrition, yeah, maybe see a nutritionist, if there's mention of it. They just put them on immunosuppressants. They hope to get them out of a flare-up, which works very well, and it's a good thing to do. Except the problem is there's a lot of side effects associated with that, and they're not really looking for cause. From a holistic or functional perspective, we want to look at cause. So what's the pathophysiology here? Well, the initial lesion starts out as an infiltrate around what's called an intestinal crypt. I'll show you in a moment what that looks like. This goes on to develop ulceration first in the superficial mucosal layer, and then goes deeper into the layers of the colon. And as the inflammation progresses, you get what are called granulomas, which can involve all layers of the intestinal wall, and that's where you get that classic cobblestone appearance. So again, back to sort of this picture here, the cobblestone appearance of Crohn's disease. You can see here. So these crypts in here get inflamed. The intestinal wall starts to become inflamed. You have this patchy inflammation that goes throughout the large and small intestine for Crohn's. This is a cross-section view of basically the inside of the colon. So if we start here at the mucosal layer, that's again where we have these little crypts. And just think of like, if you have runoff right into here, into these little crypts here, it's all inflamed, it's not coming out. It gets filled with mucus and pus, and it's hard to get that out, and you develop little infections in here, and this starts to eat away at the layer of the colon. And then you start to move submucosa, and you have these glands here. Again, fluid getting in here, infection, infiltrate in there, and it's hard to get out once it's in there, right? So you start to develop more and more inflammation. And as I showed you earlier with the fistula, you can start to go through the wall of the intestine all the way into the serosa here. So we have different layers, the muscular layer, and as you start to get that fistula, you're breaking through the intestinal wall. And if you look at all the nerve endings here, again, this could be a very painful experience for patients and cause a lot of discomfort. So patients who have irritable bowel disease, whether it's Crohn's or colitis, they're very uncomfortable. They could have nerve pain. They could have, just belly pain. They'll have, commonly irritations along the digestive tract, which might be causing loose stools or frequent bowel movements. It could be mucus. It could be blood. It can be where they get constipated and they have loose stools, go back and forth. The key point to understand here is that this is an immune response. This is an immune response. And I think that's often sort of missed. It's like, well, what can we do about the immune response? Can we calm that down? Are there other means to do that? So we'll talk later on about how to diagnose Crohn's, or what kind of things to look at to see, how severe it is. People have different levels of severity. But you look at some blood tests also that you want to highlight. Is there an anemia? Because we can lose iron absorption, or B12. Is there liver disease? Because as time goes on, your digestive system becomes aggravated. We get what's called a gut, that things are moving into the bloodstream that should not be moving into the bloodstream because of all this inflammation. And you can start to develop antibodies against the gut itself. You get heightened immune responses. And so there are certain markers that we're looking for there. One is called calprotectin, and that one is a stool marker that's very important. It shows you the level of inflammation. So What's interesting to me here again is what they're showing here is before the initiation of any treatment, we must discuss vaccination history. Has a person been vaccinated against tetanus, diphtheria, HPV virus, hepatitis, flu, mumps, you know, shingles virus, right? And why? Why do we want to know this? They want baseline chest radiograph. There's nothing going on in the lungs. The reason this is because, again, the medications used to manage Crohn's disease, because it's not a cure, but to manage it is simply to suppress the immune system. And so if we're going to suppress the immune system, then we want to make sure that people have, ample immunity to their condition, because what happens, we've all heard of, AIDS or acquired immune deficiency syndrome. Well, you can have a medically induced immune syndrome from the medications that are used to treat Crohn's. So this, I don't want to get too complicated here, but I just want you to understand that your immune system is complex, but it's fairly simple to look at if we look at it from this perspective here. It's teeter-totter, and there's a balance. And you start out with these what are called CD4 or helper cells. These cells basically are progenitor cells, and they can push your body to produce other types of immune cells. So we want a balance of Th1 and what's called Th2 cells to be produced. When there's an imbalance, then things start to go awry. And with the medicines, what they do is they push down that teeter-totter, both sides. They'll push the Th1 and Th2 response, completely, disregard the immune system. Again, that will help initially to bring down inflammation, but the side effects and what that does to somebody long-term really can wreck their quality of life. And that's why so many patients come into a functional medicine office, will, look for another solution or a solution in conjunction with that. They just don't want to be on these medications long-term if they can avoid it. And a lot of my presentation, or at least my messaging, is that there are signs of Crohn's and irritable bowel disease way before a person is diagnosed. So for you to get diagnosed with Crohn's or colitis, it has to have gotten pretty bad. And then there's different levels, right? You can have a mild disease, a moderate disease, or severe disease. But what's before the mild, right? Before that, there are symptoms of GI dysfunction. There could be heartburn, there could be, reflux. You could be on proton pump inhibitor. Patient could be, experiencing more food sensitivities, where they're all of a sudden allergic to dairy, they're not tolerating sugar, or they find that, they're getting rashes a lot when they're eating, or their stomach is bloating, or they're finding loose stools or constipation. It kind of looks maybe more like IBS, but if the genetic predisposition is there, it could shift. So we want to keep the immune system balanced, and we want to watch out for early symptoms. So the medical treatment, again, depending on the disease, they usually use a medication called mesalamine, and it's an immune modulator. What's interesting to me is the exact mechanism is actually unknown. So we're saying we don't know what causes the disease. We don't know what the mechanism of the drug is, but we do know it does suppress your immune system. And so that's the treatment. And I just, I think it's really helpful for patients that are at a place of, moderate to severe disease, but it's just not a great long-term approach, in my opinion, as a standalone therapy for Crohn's or and that's coming from my experience with patients who I'll show you later in the presentation. We're able to find other. So this is just showing you what I mentioned earlier, that there are different medications that actually can cause flare-ups or actually start the process of Crohn's or colitis. Now, there's some controversy here as to whether or not it was going to happen anyway, and then taking one of these medications might have just pushed that person over the edge into disease. And I think that's probably accurate. There's probably a lot of people who are walking around predisposed. They're having some GI issues. They're not quite at Crohn's or colitis yet. They get on one of these medications for a variety of reasons, and boom, all of a sudden, there they go, and they have their diagnosis. So Accutane is a medication that's used oftentimes for young adults who have, cystic acne, and it prevents inflammation in those cysts. And as a result of that, it actually works really well to clear the acne. However, if I had to tell you that there was one medication that I would say a great majority of my patients over the 20 years who have had more severe digestive issues come in with a history of, it's, and I think that that is echoed in many practices and clinical experience, but also in what they're finding is that, there's this correlation between the timing of Accutane or taking Accutane and getting the disease Crohn's or ulcerative colitis. And again, that's because it has some impact on your immune system. So a person could have been predisposed and they sort of tangled with their immune system. And boom. Same thing with NSAIDs. In fact, there was a study of 105 consecutive cases of colitis. 74% of the cases had been taking NSAIDs prior to or during the development of the disease, compared to only 20% of control. That's a lot. That's a big difference. So people think NSAIDs are just safe and we can just take them, but that's definitely not the case. Interesting, again, is that what you'll find is that Crohn's patients, irritable bowel disease patients, they tend to have manifestations in the skin also. So they'll have things like eczema, psoriasis, just all kinds of itching and just skin problems that tend to show up for them. And so rosacea. So it's not. Again, it could be the medicine pushing things over the edge, pushing a process that's already going on. So you need medication for your skin. You also tend to have a lot of joint pains. And so what is it? It sounds very autoimmune to me, right? So someone might be having joint pains, so they're taking NSAIDs. And then what they didn't realize is their gut, part of the reason they're having joint pain is because they've had a leaky gut for a long time. It hasn't been as bad as Crohn's. It's been building up to that. And then taking the NSAIDs for the joint pain actually leads to the problem or pushes them there faster. Antibiotics, people take those all the time for ear infections, whatever, urinary tract infections, and then wind up going to a doctor and having digestive problems that are turning into irritable bowel disease. Another big one, oral contraceptives. And just to go back to the antibiotics for a moment, the antibiotics cause disease because they wipe out all your good bacteria. And you need that good bacteria. And if you remember what I showed you initially in the etiology or how Crohn's actually is caused in the body, one of those has to do with lack of good bacteria or having the wrong bacteria in your gut. So if you take antibiotics multiple times over your life and you change that balance of good to bad bacteria, well, then you're more susceptible, not just to Crohn's, but all chronic conditions. And this is something that we have been finding over the years. So we really want to use antibiotics initially, and not just because we have an infection every time requires an antibiotic. There are other solutions. Of course, there are times where it's warranted. I think as a culture, we just tend to use way too much, and now we're back to the Western culture of wrong foods, processed foods, antibiotics, oral contraceptives. Many young women today and women in middle age get on oral contraceptives. Of course, that might be done for birth control, and that's completely understandable. However, I think it's the approach that is a little bit frustrating to me, since I see the patients who don't feel well after using oral contraceptives, that it's given out almost like candy. It's like, oh, your menstrual cycle is not going well and you're 15, go ahead, start an oral contraceptive, you'll feel more comfortable. And I get it, and they do. Except that maybe there's a reason that the cycle is aggravating besides the normal, as a woman, it's you're getting your cycle, maybe uncomfortable, of course. I sympathize with that. However, that's not what's happening. There is an education. So you should warn a woman before you give her contraceptive that, hey, this has side effects, like real consequences that you may have at some point. Stay on this. Because estrogen in the birth control pills has an immunological impact on the body. So we see today an explosion of high estrogen in women, autoimmunity, and this is one of the reasons why more women have autoimmune conditions than men. So I just think that we need to really think about these things a little bit more, and that we work through and try to find other solutions that might be just as effective. And then there are other various biological medicines that all balance as well that I'm not listing here, but this study points out these and more. So again, there's a microbial imbalance in inflammatory bowel disease. A substantial imbalance is observed across 4 major bacterial phyla or groups, including the Firmicutes, Bacteroides, Proteobacteria, and Actinobacteria, okay, which together are 98% of gut microbiota. Fun fact, you have more bacteria in your gut and your body than you do your own cells. Let that sit for a second. Your body is actually more bacteria, virus, and other microorganisms than it is you. So we live together symbiotically. We have bacteria throughout our entire body. Again, more bacteria in our body than our own actual cells. So, there's a way to live with these things, and in a modern culture, again, eating processed foods, we're not replenishing with good bacteria. Stress will actually change your bacterial counts. What you eat will change your bacterial counts. So back to the fruits and vegetables, more fruits and vegetables actually feeds the good bacteria. Processed foods, sugar, alcohol, high-fat diets, these things tend to actually fuel the bad bacteria. And of course, antibiotics. So again, it's important to understand that the pathogenesis of inflammatory bowel disease is multifactorial, okay, and it results from an interaction between genetics, immunity, microorganisms, and environmental factors. So what are the triggers? So in simple terms, diets high in processed foods, sugar and fat, i.e. a Western diet, stress, history of antibiotics, in particular penicillins, cephalosporins, and some of the fluoroquinolones, exposure to mold in a water-damaged building or home. That's one that is near and dear to my heart. I got sick 15 or plus years ago in a building that I worked in New York that had water damage. I didn't know. I was developing food allergies, brain fog, digestive issues, went to doctors, all my blood test was normal, nobody knew why. Turns out it was mold. And I can tell you, functional medicine for 20 years now, this is one of the most common reasons that people see me is they don't know it, but they had a really bad exposure, or they might know it. And it's missed in medicine. But mold is a microorganism. It comes with toxic effects to the liver, to your digestive tract, your hormonal system, and neurological system. It could really upregulate your immune system and drive people into autoimmune. So something to definitely consider. Alcohol and recreational drugs, insecticides, prescription drugs like Accutane, NSAIDs, which I mentioned earlier, infections that you may have gotten, food poisoning, things like that, viral, bacterial, fungal infections, again, could be from mold exposure or other infections that you've had in the past. All of that could trigger the immune response, and then the immune response is triggered in the digestive system, where you hold quite a bit of your immune system is isolated in your digestive tract. And then dysbiosis, which is altered microbiome. So that goes back to the antibiotics, poor diet, all that changes your microbiome. So this is, I think, the easiest and best way to really understand what's going on here. If you see this tree, the trunk in the middle is showing you the DNA helix, right? That's the genetic predisposition, right? So if you have that trunk, you're more likely for any of these fruit to bear, right? So the fruit on the tree could be migraines, it could be Crohn's, it could be thyroid disease, irritable bowel syndrome, non-alcoholic fatty liver disease, Hashimoto's, insomnia, you name it, lupus, autoimmunity. It's really all in the realm of chronic disease. And chronic disease mostly has the same causes. And you read all the time in medicine, we don't know what causes this, we don't know what causes that. But in fact, we have a lot of really good leads, a lot of really good leads. If you look at the bottom here, it's the roots, right? It's where you get your nutrients. That's what matters, right? That's what's going into that tree. And that what goes in is going to trigger those genetics to turn on or not, termed epigenetics. So if we were just the influence of our genetics, not environment, then whatever your genetics say, that's what you're going to be, and that's that. And that's the disease you're going to have. Well, that's not the whole story. That's actually a smaller part of the story. The larger part is the roots on the bottom. So if you're, grew up eating fast food, maybe you took a bunch of antibiotics, we're all exposed to plastics. Gluten is a very inflammatory food. Heavy metals from lead paints, heavy metals from electronics, from environmental mercury in fish, in the water, in the fish like swordfish and tuna, recreational drugs, just stress. Stress alone can change and turn on genetic predispositions. I mentioned mold, refined sugar, pesticides, the Roundup, we know that causes many chronic conditions. So, all of these types of things, synthetic sweeteners, people that are using things like Splenda, Equal, these have real consequences in your body. And again, I've seen that over the last 20 years in working with patients and actually working on these things. The quality of life can greatly improve. Even once the genetics have been turned on and the fruit has been born, you could still improve your quality of life by addressing the soil. Because the tree, even when it's not, you've seen a tree or a plant that's been wilting, but when you give it the right things, all of a sudden you can bring it back to life, right? Not going to necessarily be perfect, but it's going to be way improved. So there are studies that show that there are dietary protocols that work for inflammatory bowel disease and many other conditions, except they're not well publicized. They're not on, hundreds of thousands of people, right, that have these diseases, because the money is not there. The interest is not there. The interest and the money is in the pharmaceuticals. So that is why people always ask me, how come my GI doctor, my gastrointestinal specialist, did not, review some of these things with me, did not really delve into diet or some of the things that we're talking about. And the simple answer is they're not getting the education, and it's just not that much on their radar. I do think with the internet, things might be changing some, but certainly not fast enough to help people that are suffering. So despite diet being implicated in the pathogenesis of irritable bowel disease, we have limited data to guide the use of nutritional therapy or either primary or adjunctive treatment for these conditions. So they just don't do it. Conventional medical therapy for IBD focuses on suppression of the immune system by targeting a variety of pathways, yet response rates continue to remain suboptimal. Therefore, there's an important need to study dietary factors that will not only help but improve the response to conventional treatment, but also potentially be used as a primary therapy or maintenance therapy for patients with IBD. And that's what I've been doing in my practice. I didn't wait for all of this to come out. We've been using these treatments for quite a while, the autoimmune protocol, diet. These are certain diets that avoid gluten, refined sugars. Sometimes we don't have to avoid all of these things here that are listed, but sometimes that's a good place to start. And what we know is that these foods can trigger intestinal inflammation, dysbiosis, and symptomatic intolerance. So the diet emphasizes consumption of fresh, nutrient-dense foods, and it addresses these factors like sleep, stress management, right, physical activity, because these are all things that bring down inflammation. So here's some results, okay? So this is just showing you studies that have been done. And if you go down, there's a marker here called fecal calprotectin, that's FC. Where you see FC, that means fecal calprotectin. This was a study that showed the effect of AIP diet on the stool testing, looking for this calprotectin, which is an inflammatory. In week 0, the first line there were 200, the fecal calprotectin number was 267. In week 6, it was 157. So that's quite a bit of an improvement, over 100 points. In another study, the fecal calprotectin on the one that you see there, there was 471 was the average fecal calprotectin, and it went down to 112 on this dietary approach on week 11. All right, so we can see that there's a huge influence. That is the main marker that's used for Crohn's and colitis to determine if there's inflammation in the digestive tract, specific to the digestive tract, has gone down. Those are extraordinary numbers. If you got those numbers with medication, the doctor would be extremely happy. So what is very important for people to realize is, while this disease is chronic and there is no cure for it, your quality of life can improve because the patient has influence over the disease more than what they're being told. So I'm going to finish up here with a case study. 33-year-old female visited my office, had visited several gastroenterologists before, diagnosed with IBS first, irritable bowel syndrome. So we talked about that. Maybe you'd have IBS and then it would tip over, followed by irritable bowel disease, and then ulcerative colitis. This patient was having suicidal thoughts because, there's a typo there. It says he, but it should be she. Was not getting help, just being more fiber, was anxious and depressed. And one thing to understand too is fiber can actually aggravate ulcerative colitis during a flare-up. And one of the things I find in practice that's so important is that you have a patient that's coming in and they're really struggling, with their digestion. People don't lightly go to a specialist. They're really struggling. And oftentimes they don't get the time that they need. I mean, you really need to sit with a patient for 45 minutes, hour, to really understand what's going on in their life. What are their stress levels like? What are they eating? Did they ask what they were eating? I mean, a lot of times the GI is not even really asking what your diet is. So saying take more fiber, maybe that happened, before they fully had the diagnosis. When a person's in a flare-up, fiber, like if you're eating salads and things like that, can really aggravate that flare-up. So there is a time to eat more fiber in these conditions, but not necessarily during flare-up. And I've actually found to be helpful to pull out fiber flare-up for most of my patients. But it's all done on an individual basis. You really have to know the patient, see how they react to things. To do that, it takes a constant approach, which takes time. You can't see a patient this month and not see them again for 3 months and think you have any idea what their diet looks like. So the question I asked the patient when they start, do you think you know how your condition started? What do you think? The patient answered, yes. I took a course of Accutane about 4 years ago. Things have been different since. My most recent flare-up or aggravation was after a course of meloxicam, right, NSAIDs. So, which is used to try to help get him out of the flare-up that he was having. So those were 2 medications that we know can precipitate this disease. This patient probably had the disease before, and then was, the beginnings of it were there. The stage was sort of set for different reasons, a variety of reasons, and then boom, he took the medications, and bam, there it was. The symptoms when he came in were diarrhea, incomplete bowel movements, digestive rumbling, swollen rectum, gas, bloating over the last 4 years. He was fatigued, depressed, anxious, had low motivation, and a low libido. I mean, you don't feel good. I keep saying, had a low sex drive. This was really affecting quality of life, a 33-year-old, for anybody. So the prescription drugs from the GI specialist include prednisone, and a rectal foam that was used as well. And so initial symptom relief there was with the medication, followed by the flare-up again using the meloxicam, which is being used for wrist pain, because remember what we said, a lot of patients with IBD also joint involvement. So they'll feel joints, knees, wrists, hips, elbows, wherever. So what was our treatment? We did a functional holistic approach. We did what we call a repair diet. I removed the patient from gluten, dairy, alcohol, I counseled the patient as to why this would be important, gave them a very specific protocol with diet, with recipes, so that they were empowered to do it. And we removed some of the nightshades like eggplant and some peppers to aggravate the digestive tract. We had a bi-weekly visit schedule to review diet, adjust the diet accordingly. And so that was the dietary portion of the treatment. Then we had to do things to actually help that cobblestone appearance, or in ulcerative colitis, the inflammatory appearance to treat. We have to actually fix that, right? So changing your diet is going to go a long way in reducing flare-ups, in promoting good health across the board, and just calming down the whole immune response. But it's not enough. There needs to be obviously treatment. So we treated the dysbiosis with spore-based probiotics. So we used actual probiotics, and I'll show you in a minute some of the lab values. But we did what are called spore-based probiotics. So back in the old days, you would lift an onion from the ground, it had all this dirt on it, you bite it, you actually get what are called spore-based probiotics. They survive your digestive tract and they grow and multiply in the digestive tract. Butyrate is a short-chain fatty acid that we used in supplement form. It's known to have anti-inflammatory and immunomodulatory effects. It's currently actually being studied in long-haul COVID because it can reduce inflammation. And it modulates the expression of the immune system where that teeter-totter becomes balanced. And then we used a peptide. A peptide is a sequence of amino acids. They can be injected sometimes, or they can be taken orally. In this case, we use oral, which is what is usually done for digestive function. And it has various proposed mechanisms of action, including promoting nitric oxide synthesis, which decreases, helps the blood vessels essentially, which helps with inflammation. It activates cells too that are involved in tissue repair, stimulates the synthesis of growth factors, which again helps to repair, and inhibits inflammation. I use a lot of peptide therapies in my practice. Peptides are, like I said, amino acid sequences. Insulin is a peptide. That's a well-known peptide, but there are so many other peptides out there that are really great because they have little to no side effect profiles, very safe, and can be used for a lot of different conditions. So just some research showing how oral butyrate for mildly to moderately active Crohn's disease can be helpful and actually be just as effective as traditional medical treatment. So oral butyrate is safe and well tolerated and may be effective. What that does is it feeds the good bacteria in the digestive. It's clinical improvement or remission in Crohn's disease. Of course, we need to do larger studies because nobody wants to study butyrate because you can get it at a very reasonable cost. And some of these medications can cost up to thousands of dollars a month, eventually to treat Crohn's and colitis. So realistic. Focus on ulcerative colitis, stable gastric peptide PPC 157, maybe the new drug stable in human gastric juice. It's effective both in the upper and lower GI tract. So I use this for esophagitis as well. It's free of side effects, and it just has a lot of benefits. It shows that even in severely impaired conditions, that you can control it. So this was a stool test that we did with this patient. And what we're looking for here are bacterial pathogens. Remember early on we said there could be pathogens associated with Crohn's or colitis. So we're looking for some of these pathogens. So we didn't see any here. This was done in September 2020. We saw here that when we got to the normal bacteria, those are the ones that we talked about earlier, the lactobacillus, bacteria that you need, the bacteria. These are the bacteria that you need to have balance in your gut, the bacteria, the Fumicetes. So you could see now she's coming in low. So you see low marks, right? So they're showing we don't have enough good bacteria. And of course, there's been a history of antibiotics and lower these bacteria counts. And then we see because of that, what we call dysbiotic overgrowth. So there are certain bacteria now that are growing in higher amounts in the stool. This is in the stool coming from the colon. Not have there in such high amounts. And that's because the imbalance of bacteria. We see a lot of blood Okay, it should be less than 10. It's at 118. The immune response, secretory IgA is low. Secretory IgA is a marker of the membrane where you make your antibodies. It protects you. It's a barrier function. It protects the barrier in your gut. It's basically your immune response in your digestive tract. It was low. And then, of course, the big marker we talked about, calprotectin, which is showing basically that he's got huge amounts of inflammation. If you remember the study I showed you before, the average calprotectin was about 300 to 400, right, for people that were suffering. And it went down 100 to 200 points with the right. Here, he was at 3,350. This is after conventional medicine. They didn't counsel him on diet. They just left him with the medicine, and he was just, gosh, I don't know why I keep saying he. So in any event, the calprotectin, we did a follow-up 3 months after the protocol that I showed you, which was the repair diet, the butyrate, the BPC peptide. 3 months later, his calprotectin down to 283. It's still a bit higher than normal, but gosh, I mean, this is night and day. And obviously, those are a huge improvement in its quality of life. All right, so I want to thank you for all of you that made it to the end. And it's been a pleasure talking about Crohn's and colitis today. Take care and have a great day.